Welcome back to the Gillett Health Podcast, where we give you tools to develop a balanced approach for health. I'm Dr. Kyle Gillett.
And I'm James O'Hara, nurse practitioner. Today, in our clinical series, we're going to be covering a new risk that's been associated with Omega-3s. A lot of people like to take Omega-3 supplements. I think maybe even a quarter of the population in the United States may be taking an Omega-3 or fish oil supplement. So what is this new warning about?
Yeah, there's something fishy going on with AFib in this country. There's a lot of proposed causes, but one of the risks is association of EPA or Omega-3s with atrial fibrillation.
And for people who don't know, atrial fibrillation, it may feel like a fish is sort of flopping around in your chest, but what is AFib if someone doesn't know?
Yeah, so AFib is a rhythm or the start of a beat that is not congruent with the rest of your heart. So you can think of the heart as, well, four chambers, but two main areas. The atrium are on top, and then the ventricles are on the bottom. You have the right side, pumps to your lungs. You have the left side, pumps to your body. And AFib usually comes from a small area in the very top of the right atrium, actually usually in the pulmonic vasculature, like technically not even in the atrium. That's where you might have heard of, someone got their AFib zapped or corrected. That's just where they find where that abnormal beat is
coming from.
Yep.
Yeah.
And zap it. But anyway, AFib in general is one of the most common arrhythmias. We've talked about it before on podcasts, as it is a risk in at least high-risk individuals that are on TRT.
Yeah, that came out of wasn't the primary endpoint, but did come out of the recent New England Journal of Medicine paper. So this was a pharmacovigilance risk assessment committee. This is something that happens in Europe. I'm sure we do the same thing on a periodic basis here in the United States. And this is part of the European Medicines Agency. And they just met. This was about, 6 weeks ago at the time that we're recording this.
Yep.
And they met for 3 days, September 25th through 28th, and decided to add a warning label to not just the Visipa, which is a pure EPA product, but also to omega-3 ethyl ester containing products. So this would be your generic Lavazza, and even very similar, in some cases identical to what you're getting over the counter.
Yeah, so immediately after this came out, I, of course, cut out all EPA, DHA, DPA,
even
all
fish.
Omega-3s, including fish in my diet. But wait, it's an essential fatty acid. How can this be a risk?
Yeah, it's a bit counterintuitive, because when you look at some of the preclinical data, there's association between fatty acids like EPA and DHA, and it seems like these are antiarrhythmic. But then when you look at high-risk populations, they seem to be very pro-arrhythmic. And to complicate things even further, there's a sort of observational study that looked at the populations and their actual biomarkers, so not just reported intake of, hey, I eat this much fish or I take this much omega-3, but basically just dietary assessments. And then they sort of fact check that with, okay, how much is in the adipose, how much is in the serum, how much is in the red blood cell membrane. And they found if you slice it between the lowest 20th percentile and the highest 20th percentile, so 80th percentile of omega-3, and they stratified it by DPA, DHA, and EPA, all three showed a protective effect, with DHA being the most potent, twice as effective, if we'll call it that, in terms of EPA, or associated with a 13% reduced incidence of AFib.
So that's confusing. That's the opposite of what they said. So this agency tells me that omegas cause AFib, and then this other study says they don't cause AFib. Perhaps the dose or the content of omegas in their diet was different between those
two
dose
groups. Makes the poison. Yeah, that is one of my favorite sayings. And that does turn out to be the case. It's interesting because these were kind of stacked closely together. Basically, this paper was not trying to say that omega-3 supplements were not risky. It was just reinforcing the dietary guidelines, saying, hey, it's probably a good idea for people to have, I think the recommendation is 2 or 3 meals of fish per week. And basically saying, hey, yes, with that level of omega-3 intake, looks like it would correlate with a reduced incidence of this AFib. And the average daily intake in these populations is around 0.5 gram, just under, so about 430 milligrams per day.
Yeah, and in addition to that consider the average health or the average phenotype of someone with a bottom 20th percentile omega-3 content, they probably don't have a very healthy diet otherwise. So they're going to be, again, this is a correlation with low omega-3 content and AFib risk.
Yeah, it's like the healthy user bias or the healthy individual bias, where people that tend to have a higher omega-3 index are probably doing other positive things for their health. And I believe some disease states will also deplete omega-3 in the body. So, there's a lot to unpack there, but as we'll talk about, it kind of does line up, at least directionally, somewhat with some of the other data that's out there. There were really 4 big randomized controlled trials that I think led to this. So you had number 1, the OMINI trial, showed an increased risk of AFib 7.2% versus 4%. This was 759 patients, and this was their risk of AFib. So that was, I believe, it's like a 1.8 something hazard ratio is what spun out of there. Then you had the strength trial, also showing increased risk of AFib, 2.2% versus 1.3%, over 13,000 patients. Then you had reduce it. This is interesting because this is the one that showed the strongest protective effect. I think the reduced incidence of MACE, major adverse cardiovascular events, was in the range of 25% with this one. And AFib incidence was increased 3.1% versus 2.1%. And these are absolute risks. So this is relatively small absolute risk, but a pretty substantial relative risk.
Yeah. So depending on if you're pro-omega or anti-omega, you say it's a 1% absolute risk or a
80%. Yeah.
Or
if you're talking about the OMINI, it could be as high as an 80% relative risk increase.
Or that if you're anti-omega, of course, we're here for a balanced approach to health. So if you think about it, you're thinking about the dose, and you're also keeping into context what the indication of the omegas are. So I guess our job is not to sit here and say, oh, when we put omegas on the overrated supplement podcast, if people remember, we did overrated supplements, and partly to click to get views, but also partly because with the many benefits of omegas, mega dosing omegas is overrated for general cardiovascular health, and AFib risk is part of that.
Yeah, even in these 4 trials, the 4th being the VITAL, which did have a hazard ratio of 1.09, so it was supposedly not statistically significant. This was the lowest dosed omega-3 trial, so it was considered a neutral finding. I don't believe it showed any improvements in adverse cardiovascular events either. So the trials are mixed. So if you do have a cardiologist that says, hey, you should be on Vascepa, they're probably thinking to themselves, this person's going to potentially walk out the door and have a heart attack on me. We want to put everything we can in their corner to hedge against that happening. That's probably a good choice. If you are taking 6 or 7 grams of omega-3s just because you heard your favorite influencer is doing that, or some company told you should be doing that, then that probably needs to be evaluated in context of what is your risk for AFib. Do you have any other health conditions that could sort of be the catalyst to flip you over into an atrial arrhythmia?
So as a functional medicine doctor, I should probably stop telling all of my patients on Eliquis and aspirin or Eliquis and Plavix to stop all of that and start 6 grams of omega because it's a blood thinner. Because my surgeon told me to stop all omegas and blood thinners before my surgery last week.
Yeah, and that's just per protocol. I see that a lot. So on the stop this before your procedure, it will say, stop X, your blood thinners, your aspirin, don't take ibuprofen, St. John's wort, all these different things. And it'll add omega-3s or fish oil into that. But there's been randomized trials with really hefty doses of combination. So that's the key there. It's not just 4 grams of EPA, but a combination of EPA and DHA in the 4-gram range. And then they take those patients to open heart surgery and they don't see an increased bleeding risk. So it's just more time efficient for the surgeon to tell everyone, hey, stop your fish oil, than to say, okay, well, how much EPA are you taking? How much DHA are you taking? Surgeons don't really get paid to do that.
Yeah, the other way to look at it is it's not as strong as an anticoagulant or an antiplatelet as prescribed anticoagulants and antiplatelets. I did stop my aspirin before my surgery.
Good choice.
Yeah. Anyways, we're rabbit trailing a bit here. We can move on.
Yeah. And then other observational studies and looking at some different countries. Basically, the summary is it needs more research. One showed an increased risk of AFib with more. This is just dietary consumption of fish. That was in younger adults. One showed a decreased risk in older adults. And then there was another study that showed no change in risk of AFib, regardless of the dietary fish consumption. So I wouldn't worry at all about like how much fish you're eating and whether that's going to affect your AFib risk. There's much larger basic principles of diet that I think people should focus on first. And then really just kind of evaluating what you're doing from a supplement standpoint. And we'll kind of talk about what some of the results are, looking at the primary reason people are prescribed omega-3s, which is for reducing the risk of a heart attack, stroke, those sorts of things. So this is a chart that's showing us the reduction in plaque progression. So you have a group here that was sort of the summary, like the average. Then you have people taking no EPA, low EPA, and high EPA. And interestingly, in the high EPA group, they included EPA only. And then also a combination, basically 4 grams of ethyl esters as well, lumped into that category.
Yeah, pretty interesting. The difference between the omega-3 ethyl esters, which is usually about half DHA, half EPA,
is that one's generic and affordable, right?
Yeah. It's been compared to icosapent ethyl, which is basically just EPA ethyl ester, which is pure EPA. And I suppose if you had a patient that has like familial hypertriglyceridemia or extremely high triglycerides, it's also cardiovascular risk, then that could make sense, especially if they're not having to take something like niacin or a fibrate in lieu of that. But yeah, compared to for general health optimization purposes, we actually prefer the mixed omega ethyl esters or the generic Lovaza.
Yeah, and again, it's probably for the general healthy person, not a huge, I mean, I don't even know if you could detect that risk even in a large study over several years.
Yep.
But to hedge on the side of caution, that's the approach that we tend to take. So basically here you see a dose-wise progression or lack of progression actually. If you don't take any EPAs, and these patients are all on standard of care, so statin, aspirin, beta blocker, you don't add any omega-3s and you see their average, again, small numbers, but about 20% plaque progression, so an increase in that atheroma volume.
Yeah, how'd they measure that plaque progression? Surely not something like a CCTA, because cardiologists don't really recommend those.
Well, the cardiologists that were involved in this study did.
That's interesting. Not really seeing that in practice yet, but commonplace among publishers and I guess academic centers.
Yeah, and our patient population for the right candidates. And next you have the low EPA dose. So this one, I believe, was in the realm of something around 1 gram, maybe 2 grams of EPA with no DHA. And it had a slight reduction, right? 15.7% increase in atheroma volume. And then the EPA high had the smallest increase in progression, 5.6%. But what I think is the most interesting is this chart right here below this. So they lumped both high EPA and DHA and high EPA alone, which is only 1,800 milligrams here, into the same group.
Yep.
Those on the combo, 0 of them had plaque progression. 5 of the patients had plaque progression on the high EPA alone. So it's really interesting to me, and it's not statistically significant because of the small numbers. But if you have 20 patients on this high-dose EPA-DHA combo and none of them had plaque progression, that seems to bode pretty well that, and the conclusion from the paper was this, that the DHA is definitely not interfering or minimizing that benefit of the EPA. There's other benefits of EPA that the DHA may attenuate, but the plaque progression doesn't seem to be one.
Yeah, we've talked about other benefits of DHA in the past, I think in our All Things Fats episodes, post-TBI, football players, military, etc. But this is relatively compelling that it is at least non-inferior.
Yeah, and if you're looking at just someone like hedging, saying, hey, I've got a 10% stenosis, I had a CCTA, I know I've got some plaque there, I want to kind of, have all different vectors going to prevent that from going to 20, 30, 40% plaque, then a combo product could be a reasonable addition. You're not going to be missing out on anything by not taking EPA only. you're not going to have the increased bleeding risk, really. Really, you're just missing or attenuating that effect on the platelets. So if you're looking at like someone with a unstable angina, then probably adding the DHA to that is not going to be the best risk-reward ratio for them in that case.
Yeah, that's a good point. I guess another silver lining here is, although insurance won't cover it until you've had a cardiac event or a stent, you can still get it for a cheap cash price.
Yeah, or if you have a CCTA, you prove to them that, hey, I have plaque in my arteries, I'm a CAD-RADS 2, I should have a repeat CCTA by the guidelines at this interval, then they will cover it, which is interesting. I mean, it's a good summary of kind of how our health system works. You prove you're sick so that you can get coverage.
Yeah, prove you're sick out of pocket, and then you'll get your meds covered, maybe.
I still think it's a good investment.
Yeah, it is. Especially if you get your PCSK9 covered if you need it.
Yep. And then this paper, I'm going to go ahead and click into this one. So this experiment could be triggering for some people. It used animals and dogs, which people do care about more than mice in studies.
I thought you were going to say more than humans.
Some people care about dogs more than humans also. Is that speciesist? Let's see. But basically, the title of this paper is DHA, but not EPA supplementation, reduces vulnerability to atrial fibrillation. And I think this is a good study because it's not in mice. Dogs are more similar to humans. They live in the same environment. Depending on what you feed your dog, they may have a more similar diet to you. And what they did was they implanted pacers to push up these dogs' heart rate to 220 beats per minute for 2 weeks. And then one group got a gram of DHA, the other group got a gram of EPA, and the other group got a gram of olive oil. And basically the summary was EPA seemed to increase the risk. Again, olive oil is not a perfect control because it may have some benefit by itself.
Yeah.
But DHA was definitely superior. So I am in part basing my thinking about omega-3 supplementation in humans from some intervention randomized controlled trials in dogs. Yeah. What category does that put me in? Does that put me in evidence-based?
The Huberman categories of...
show me the data not in rats, but in dogs?
Yeah. That being said, it's not that you're taking away the clinical endpoint or the outcome in dogs. You're taking away the scientific concept of the protective effect of DHA, which does appear to be at least somewhat collaborated in human study.
Yeah, and the DHA also reduced atrial fibrosis compared to the no unsaturated fatty acid group, whereas EPA did not. So interesting paper. Again, making a dog redline at 220 beats per minute for 2 weeks. Not something I would want to be a part of, as far as being the one conducting that study, but I am glad that it was done because it gives us a good piece of data. And then there's a lot of other experiments going on with dogs. Matt Caberline's dog aging project, I think, is going to give us some interesting insights. Already has a bit.
Yeah.
One of the interesting side effects there of rapamycin in dogs is increased activity. So if you have a lazy dog, they might just be rapamycin deficient.
Yeah, I do have lazy dogs, and even when they're on rapamycin, they are still lazy. So
non-responders.
Doesn't work for wolfhounds, at least, or at least not that I can perceive.
Yeah, so you mentioned the DHA trial looking at reducing, I think it was neurofilament light chain after a head injury.
Yep.
That was a DHA only supplement. And basically what I'm doing here is building my own case about a potential pivot in myself from a 50-50 split to something that's a little bit more DHA heavy as far as my own supplementation. I think Thomas DeLauer has been talking about a higher DHA for quite some time.
Yep.
I don't know if it's based off of some of this evidence or something else he's read, but it looks like a really reasonable trend to sort of steer the direction in.
Yeah, I know Thomas occasionally likes cod liver oil, krill oil sometimes. I know there's lots of benefits to including astaxanthin content in your omegas, which is naturally occurring in things like krill. It's just the xanthophyll. It's a pigment. And as we'll mention later, it can actually interfere with the assays used to test for oxidation. I think there's a good podcast, a good clip. Derek with More Plates, More Dates is talking with Thomas DeLauer about oxidation of fish oils and whatnot, which we'll get into later too. But basically, there's a lot of mixed evidence. But yeah, I guess this is also just another excuse to where we can take the pregnancy omegas, because usually high DHA, you think that's your prenatal omega.
Yeah, absolutely. So I compiled a list of studies here thinking to myself, what benefits am I likely to lose if I reduce the reduce the EPA down to something like 500 milligrams. So a level that I don't feel is going to significantly increase the risk of AFib. And that, again, I said feel, not the data show. That's my feelings. I don't really have a great data set to point to there. Now, if someone is depressed or if someone has, for example, a lot of inflammation and they're in a hypercoagulable state, the EPA starts to make more sense, risk benefit. But as far as some of these other things like blood viscosity, the rigidity of your red blood cells, and even blood pressure, that was significantly reduced after 5 weeks of omega-3s. And this was with a slightly higher DHA to EPA content, so 1440 milligrams versus 1080 of the EPA. So you're not really missing out on that much blood viscosity. Our next one here is kind of summarized. What's that? An increase in LDL? How does that work?
That's good. That raises your testosterone, doesn't it? It's lean mass hyperresponder.
That must be.
Yeah, 2 to 3% increase in LDL, and they actually did stratify by ApoE allele genotype, and ApoE4. I don't know, was that a homozygote or a heterozygote?
I believe they were just carriers.
Carriers.
It's pretty rare to find a homozygote in the population.
They're hyperresponders to triglyceride lowering, 23% in ApoE4 males.
Yeah, and I think Rhonda Patrick recently has talked about some interesting mechanisms or potential mechanisms with DHA, the blood-brain barrier, and especially ApoE4. They seem to, like, on the one side have an increased risk, but on the other side potentially be more amenable to like getting benefits from various interventions. So they had this little increase in LDL. I mean, that's going to be 4 to 6 points in reality, depending on your baseline LDL. And then a tiny increase in HDL.
Yeah,
so
probably not clinically
maybe
significant.
1 point. And we don't really bet on HDL being the like protector of the coronaries in most cases.
Here's a random thought. Perhaps the most beneficial SNP or nutrigenomic allele is ApoE4. Because in general, for those that haven't heard our podcast on nutrigenomics or whatnot, the science is not there. Look at the work of Dr. Michael Snyder, a PhD at Stanford. The clinical significance of nutrigenomics, not pharmacogenomics, but nutrigenomics is terrible.
Is that the one?
This is technically nutrigenomics.
Yeah. Is that the one that came out recently where they looked at everyone's genes, put them on like low carb, low fat, like this is the diet according to your genes, and saw no differences at the end of the study?
Yeah.
So I saw that recently and I thought, well, that kind of confirms what I thought, that these companies saying, oh, you should eat more fat or less fat based on these SNPs. There's just so many SNPs in the clinical, like each one maybe has an input of 1%. It really doesn't move the odds a lot.
Yeah, it's great for the margin of functional medicine clinics,
if we released our nutrigenomic test and it was just an ApoE4,
oh, that would be great.
ApoE genotype, then that would actually be significantly better than any product on the market.
We'll release that at the same time as our proprietary blend of anti-aging supplement. Be on the lookout in the future for that. We'll sell it for very low cost on our website.
There's another one, supplement lowering triglycerides, increasing HDL 10% in this case, but it was combined with exercise. Also improved endothelial-dependent arterial vasodilation. And that was in addition or a degree above what was seen with just exercise alone.
This was almost 5 times as much DHA as EPA.
A 5-to-1 ratio.
Yeah, 360 and 1560.
Yeah, so I think the takeaway from this paper was in individuals who are overweight, metabolically unhealthy, then some omega-3s could be a reasonable addition to their training program.
To exercise.
Additional benefits there, with exercise, of course, being the foundation.
Yeah, exercise is going to be a lot stronger than the omegas for that clinical endpoint of increasing HDL that much.
Here's a cod liver oil study. And
Yep.
cod liver oil has a naturally higher DHA to EPA ratio, which I believe most fish products do. And in your own red blood cell membranes, there's significantly more DHA than EPA. So just, intuitively, it makes sense that we should be taking in a little bit more DHA than EPA, unless it's for a specific reason, because it's a more natural state.
That's just the natural state of humans, as most know. Paleolithic and pre-Paleolithic men consumed exclusively the liver of cod fish.
Yeah,
it's the cod liver.
The original liver kings and queens.
Yeah, definitely no fiber or fruits or vegetables or anything like that.
They specifically only went to the pharmacy and got these prehistoric supplements that were at least a 2-to-1 ratio, DHA to EPA.
Yeah, exactly. Here's another study we've talked about blood viscosity, and that's kind of related to total vascular resistance. But this one studied arterial compliance, as people know, as age increases, compliance or the elasticity can decrease quite a bit. That's why you have a widened pulse pressure. So this also reduced the pulse pressure. So I guess a takeaway for this could be, and this was a pretty crazy omega ratio.
Was it like a 15-to-1 or?
It's essentially pure DHA.
3 grams of DHA roughly and 164 mgs of EPA.
So if you're 70 or 80 years old and you have or even 60 and you have a widened pulse pressure, you're losing elasticity. You're worried about nitric oxide supplementation before that fancy nitric proprietary blend, or before the plasmalogens, or before even NMN, or before your spermidine.
It's going to be a much better return on investment as far as the cost threshold to optimize DHA before these, you just call them fancier or shinier things. Because they're getting more press right now, more marketing.
Just need to have some sort of fancy marketing name for it. Vasculogen or something.
Yeah, something trademarked.
50-to-1 ratio of DHA and EPA.
And then this one, I put this in here because I think you would find it particularly interesting. 5 weeks of basically DHA only. Again, it's like a 5-to-1 ratio here. Elite Australian rules footballers. So this is I tried to figure out what this game was. It does use an actual football-shaped ball, but it looks like a cross between American football and rugby.
Yes.
There's limited or no protective gear, and it's played in an oval-shaped stadium. That's about as far as I got.
Reminds me of a game I played as a kid called Texas Rugby, except we used a basketball goal.
Really?
Yeah.
Interesting.
Best played in the snow with a lot of coats on.
Well, that sounds like protective gear.
Maybe so.
But the interesting part here was, we know that DHA tends to lower heart rate and lower blood pressure. They were able to do the same exercise this was basically not high intensity, not max effort, but sub-maximal exercise, cardio. And they performed the same work at 7 beats per minute lower. So the hypothesis going in was, this is a performance enhancer. Maybe they'll be able to perform more watts per minute that they're in or whatever. The performance wasn't improved, but it looks like efficiency was potentially improved. At least for your middle end. And I kind of think about this as a car analogy, right? Your Prius going 65 on the highway, it's going to get really good mileage. But on the top end, if you're limiting your max heart rate, you may not be able to keep up with that Ferrari that's flying by you in the left lane, because no one's blocking the left lane, because no one should ever block the left lane.
That's true. It's poor for your health to block the left lane, that's for sure. But yeah, this is an interesting takeaway. I do wonder how it would translate to something like the Echo bike that we both like. That's the Airdyne bike or assault bike or whatever you call it. That is really known for spiking your heart rate quite high, quite quickly. And yeah, that's one of the exercises along with incline bench that we both like doing pretty frequently.
Incline bench and Echo bike enthusiasts.
Yeah.
The only 2 exercises you need. That'd be a good clickbait.
that would be. That's for a future After Hours podcast, probably. But anyway, it also made me think of overseas soccer players and rugby players and whatnot. I know Derek has made a video on this. The high amount of albuterol use. Lots of albuterol is used.
Yeah, which also improves submaximal exercise performance. So if you don't do this. But if someone hypothetically stacked albuterol with DHA, maybe they're not getting that limit on their max heart rate, but getting a bit of improved efficiency.
The English Premier League players are taking notes right now.
And then one for the other Dr. Gillett here, Dr. Grant Gillett. DHA helps with periodontal disease. This was a DHA only study, 2,000 milligrams per day, and they saw improvements in, I believe it was gum recession in this study. So I don't know if he's doing that in his practice, but I'll have to ask him about that.
Yeah, I will. That's an interesting thing. I assume that now that he can just tell people to take this supplement, they don't have to do any sort of dental hygiene or brush their teeth.
Brush your teeth with Omega-3s. And then another DHA-only study. This was kind of an interesting one if people want to dig a little bit deeper. They compared 2.7 grams of DHA to 2.7 grams of EPA on a ton of different parameters. I just pulled this one because it was really interesting. DHA increases LDL production, also increases LDL clearance, and increases LDL size. So the weight-based measurement you see on that LDL, you may not actually have as many particles. You may have a lower number of particles because those LDL particles are going to be larger and also being cleared from the bloodstream faster. Now, it doesn't seem to move oxidized LDL around, which is kind of a controversial marker anyway. But I wouldn't be worried about, again, a 2, 3, 4% increase in LDL from adding omega-3s. Because really, you have really good tools either through diet or through pharmacology if people need those to pull down the LDL.
What if you take a lot of oxidized fish oil? Does that mean you get oxidized LDL?
That's a good question. What are you going to tell us about rancid and oxidized fish oil? Because I was really comfortable with the pharmaceutical omega-3 ethyl esters, really good quality control. I do and still will prescribe those for patients because they're probably the most cost-effective form out there.
Yep.
But I think I am going to lean more towards supplementing that with a bit of DHA. So how do I make sure the DHA that I'm recommending for patients is not going to actually harm their health?
Yeah, I guess I'll answer the question first before giving a whole bunch of troll, sarcastic statements this time. But yeah, as a good rule of thumb, you want it to be new, less time to oxidize. You also want it to be in a soft gel. You do not want it to be a liquid, or apparently there's also chewable tablets and gum.
And spray.
That have omegas in it. So, and soon toothpaste, now that somebody's going to take our idea from the podcast. But anyway, you want it to be a soft gel, relatively new. If you look at the conflicting studies, there's a whole bunch of them. There's an article that will include the source too, although it's behind a hardcore paywall. The multiple ways that we usually
recommend people not
get around paywalls or whatnot, or our deep dive prescription and whatnot. Not on there yet, but we'll include that. And it looked at 73 different products, and this is basically the takeaway that they came. If it's flavored, it's also more likely rancid. So unflavored, soft gel, that's what you want to look for. If you look at a study and it says supplements with astaxanthin are bad, or cod liver oil is bad, as in it's oxidized, assuming oxidized means bad, which it doesn't necessarily mean bad. I have not seen a study on that yet. Please link it in the comments if you've seen one. But yeah, with all these conflicting studies, the assay for one of the specific oxidized products that they test for and the total toxin burden, which there's a threshold that's set by an international society, which is kind of hard to say how accurate it is, but it's better than nothing. One of them is very frequently off if they have any sort of pigment in it. So any xanthophyll like astaxanthin is going to be a pigmented.
It's going to throw off the assay, just like someone taking biotin will throw off their thyroid studies potentially.
Yeah.
Same concept.
So a lot of other people ask about triglycerides versus ethyl esters. They're like, well, you can't prescribe them. But honestly, the only time I've heard people say you need triglyceride form is someone who's paid by a supplement company or a clinic who gets part of their paycheck from a supplement company. So ethyl esters are not terrible. Yes, there's good bioavailability of both ethyl esters and triglyceride form. Triglyceride form likely does get intracellular easier, but has a shorter active half-life, if you will, in the serum. So ethyl esters kind of like easy bleed, which might be decent if you're worried about these omegas getting into cardiac tissue. So for very high dose, it might be better. Whereas triglyceride form, yeah, probably not more stable, maybe a little bit easier to get intracellular, possibly better in an older patient population. But you can also stack both together. You can take one pill of prescribed omega-3 ethyl ester. You could take another pill of, mostly DHA triglyceride form.
Yeah, I think those are really reasonable. And I may have misspoke earlier. The omega-3 ethyl ester prescription may not be the cheapest. The cheapest may be Kirkland omega-3s, which this was the first time I checked an omega-3 index. I was eating a lot of mackerel, and I was also supplementing with, I think it was 6 or 8 capsules of the Kirkland omega-3s. Because I remember they only had 300 milligrams of omega-3 per gram capsule.
Ooh.
So I didn't want to continue doing that, but I was like, well, I got these cheap. I want to use them up. So I did. And then I think it was 4 months in, something like that. Checked my omega-3 index, and it was north of 8%. So I was like, well, I think that these do have like the omega-3 in content they purport to.
Yeah.
But at that point, I did pivot to an ethyl ester product because then I could take 2 capsules instead of 6 or 8.
Less pill fatigue, less room in the fridge, assuming you keep it in the fridge. Maybe less burps if you're an individual that gets that. So there's a lot of positives to taking a more highly concentrated product. But a lot of people just get their ethyl esters from Mark Cuban's pharmacy, Cost Plus Drugs. There's GoodRx coupons that have great deals for them as well. Mm-hmm. But it's probably something that you don't want to stockpile of 5 years and then just keep using it time over time.
Yeah, definitely want those to be fresh, or at least airing on that side. So the percent here was, this was like, I don't know if it specified between capsulated, but basically if it's unflavored, there's a 13% chance that it exceeded the guideline for oxidation. Mm-hmm. I assume that number would be lower, maybe south of 10% if you're looking at it in encapsulated form, like a gel cap. So to me, that's pretty good. So that means that 9 out of 10 products I pick up off the shelf, they're in a gel cap. They're probably not going to have a substantial amount of like oxidation, or they're not going to be rancid.
Yep. However, almost 70% of the flavored products, I know for a short period of time, one of my children, Archer, tends to get a lot of concussions. I had him on a DHA protocol. There was a primarily DHA supplement, and I'm glad that he used it pretty quick because it probably did go rancid relatively quickly. Mm-hmm. But for other info on this topic, Dr. Rhonda Patrick, of course, is essentially known for this specific topic. Omega-3s, ratio of omega-3s to omega-6s, omega-3s, 6s, 9s, 12s. In the future, we might talk about special branded proprietary omegas, which occur in nature, but not at high doses, but are amazing for you. But we really appreciate any comments or insight into this. Perhaps we'll do a Q&A if we get enough interaction like we did on the dutasteride episode.
Yeah, absolutely. So hopefully we imparted some valuable info and, kind of some reassurance in the context of what sounds like a very scary warning, which for people that are high-risk patients, so if you have known coronary artery disease, diabetes, 80% of these patients have high blood pressure in these trials, then those are people where that could be kind of a tipping point. We really don't know. You can't say conclusively in the healthy general population whether that is going to be a tipping point or not, because no one is going to do that study and give 4 grams of omega-3s to healthy people, because there's not going to be much of an effect to measure. But in general, I think it's a low-risk intervention still. Personally, I just like to err on the side of caution. So I'll end up skewing a bit more towards the DHA.
Yep. We hope that you've enjoyed this episode, despite us not telling you to consume mega doses or stop completely. As always, that's just our balanced approach to health.
I'm waiting for the comment. But what ratio should I take?
Yeah.
Someone will put it there.
One thing we would say is, we mentioned this in previous podcasts as well, and this one too, is we do like to check omega RBCs. Mm-hmm. So Omega Quant. Yeah. I think it's just omegaquant.com. You can go there, you can get it from Amazon. You don't need a doctor's prescription to get that.
Or if your doctor orders Vibrant Labs, you can add an omega-3 index onto that.
Vibrant Labs is also RBC. LabCorp is not.
Yeah, Omega Check is what LabCorp utilizes. It's not quite as consistent, but there is I believe there's some conversions you can do to see what roughly your omega-3 index would be. But our recommendation is just to go ahead and get the better test, in our opinion, which is looking at the red blood cells.
Yeah, I guess we could plug our own labs here too. I think it's GilletteHealth.com/labs. You can get a complete intracellular micronutrient panel, every nutrient in the serum and intracellularly. It's kind of expensive, but to my knowledge, it's from Vibrant, and it's the only product like that on the market. It includes omegas, includes CoQ10 intracellular, includes intracellular glutathione, some really unique things. So if you want to support the podcast, that always helps. And I guess that wraps it up for today.
Yeah, I think that's a wrap. As always, thank you for your time. Thank you for listening, and may God bless you with health and happiness.